today's lecture. Today I'm going to talk about sex cord-stromal tumor, steroid cell tumor, germ cell tumor. Basically, in the ovarian, we have sex cord-stromal cells. I'm going to talk about what are they and also germ cell. In a normal status, there is no so-called steroid cell in the human being, but we do have this steroid cell tumor. So here's the figure to show us what is sex cord-stromal cell. So here's the normal structure of follicle in ovary. And this outside layer is thick cell, and the inner layer is granulosa cell. So both of these cells are the origin of the sex cord-stroma. Then try to make perfect sense for why in thick coma and granulosa cell tumor, why some kind of these stromal tumor, sex cord-stroma tumor is related to antigen-related manifestation, and then granulosa cell related to estrogen, estrogen manifestation. You need to understand what is the normal function of these two cell type. So first, thicker cell, they receive the signal from LH, and then cyclo-AMP, it can activate these desmolase, transfer cholesterol to antigen. Then antigen go to granulosa cell. Granulosa cell receive the signal of FSH, then activate aromatase, which can transfer antigen to estrogen. So in granulosa cell tumor, your symptom is related to excessive estrogen, but it's not related to any symptom related to androgen, because it makes sense. Granulosa cell cannot secrete antigen. However, when you see this thicker cell, if you have vicoma, desmolase can transfer cholesterol to antigen. That means the symptom is related to excessive antigen in vicoma. But you can also see this pathway if you have more antigen. More antigen can also go to this normal granulosa cell. And then more of this product, antigen, it can also transfer to estrogen. So vicoma, you may have high antigen symptom or more estrogen symptom. Then another sex cord-stroma tumor in the ovary, that is the Sertoli cell tumor and Leydig cell tumor. And basically, they are just counterparts of the thickle cell and the granulosa cell. Sertoli cell, the counterpart is granulosa cell, so it can also receive the signal of FSH and then secretes estrogen. Then Leydig cell receives the signal, and their counterpart is thickle cell, so it can receive the signal of LH and then secretes testosterone, also antigen. And then the IHC to highlight this kind of tumor is also makes sense. Why Sertoli cell express IHC marker inhibit? Because it can secrete inhibit. That is a negative feedback to the pituitary to inhibit FSH. So their counterpart granulosa cell also secretes inhibit, negative feedback for FSH. So inhibit is a IHC marker for Sertoli cell and granulosa cell. And then normally in the ovary, you cannot find Sertoli cell or Leydig cell, but these two cells can become tumor. So let's start to talk about the first entity for today. That is the adult granulosa cell tumor. So from the terminology, just the proliferation of granulosa cell with variety of pattern. The clinical issue is mean age is 50 years old. So compare adult granulosa cell tumor to juvenile granulosa cell tumor. They have older age for this patient group. And as I mentioned before, normal granulosa cell can use aromatase transfer antigen to estrogen. So the symptom is related to excessive estrogen. And because more estrogen, our endothelial cell can become malignancy. And the stage is most important prognostic factor for adult granulosa cell tumor. It could be really big, like the mean size is 12 centimeter and unilateral. The cutting surface is yellow to white cutting surface. Here's the gross picture of adult granulosa cell tumor. The cutting surface is like meat-like cutting surface, yellowish. And then with this cystic structure. And then they can also have this multifocal, hemorrhagic, and necrotic cutting surface. The microscopic feature, I think usually we depends on the structure, the pattern recognition, as our low power expression for different kind of diagnosis. But however, in cord-stromal cell tumor in the ovary, it's really difficult because when you see this pattern, they can have different kind of pattern, including diffuse, insular, tuberculate, core, microfollicle, different kind of pattern. So you just could not depends on this pattern to help you the differential diagnosis, though it is still helpful in the low power. And then for the exam purpose, cord-stromal body is the characteristic feature of this kind of tumor. And you should also notice, especially in the differential diagnosis, in this adult granulosa cell tumor, they have hyperthecosis. That means they have some area just really mimic thecoma. And then they also have cellular fibroma-like stroma, which is a mimic of cellular fibroma. So when you see thecoma or even cellular fibroma, you also need to think about whether it is just a component from an adult granulosa cell tumor. And then this time, reticulin staining is really helpful. I can show you the picture to help you better understand what I mean. And then the cytology for this adult granulosa cell tumor is really important. You can see scan minimum eosinophilic cytoplasm. And then the nucleus is conspicuous nuclei. You could not find any prominent nucleoli. And the more important clue is that longitudinal groove. But in the ovary, you also need to pay attention because Brenner tumor also a common finding in ovary, and then the cells of Brenner tumor also had this groove. So this is a really nice axonal, co-axonal body. So what does that mean? That is the granulosa cell just forming this rosette and then have some secretion in the lumen. So in terms of co-axonal body, but you need to pay attention. Maybe in the examination, when you see co-axonal body, you can choose adult granulosa cell tumor. But in the real practice, you need to pay attention the mimicker, including endometrioid carcinoma of the ovary, gonadoblastoma, sclerosing stromal tumor of the ovary. All of these three entities could have this structure. And as I mentioned, we can have different kind of groove pattern. This is a solid sheet. And then this high power picture also highlight this nuclear groove, really minimum cytoplasm, and then the cells look really monotonous. And then also forming this core and change growth pattern. And this growth pattern is really rare, but you may also see it. That is a pseudopapillary. Pseudopapillary, that means you can see this almost like papillary structure, but you could not find any fibrovascular core. For the ancillary text, including ISC, for this sex cord-stromal cell tumor, you always can find these 3 marker positive: inhibin, keratin, SF1, and then characteristic for adult granulosa cell tumor is FOXL2. And then as a stromal tumor, the epithelial marker like EMA and CK7 should be negative. And with reticulin staining pattern, just like what we've seen in the hepatocellular carcinoma, the reticulin fiber surrounding group or necks of cell. But if in the cellular fibroma or the sarcoma, this reticulin staining is helpful because reticulin fiber just dissect into individual tumor cell, not grab this group or necks of cell. And then, of course, for molecular, we can find this FOXL2 somatic mutation in 95% of the adult granulosa cell tumor. So the differential diagnosis, including the first one, is our endometrial adenocarcinoma. But in endometrial adenocarcinoma, you should find some squamous or mucinous differentiation, and also associated with endometriosis. Of course, our epithelial marker is useful, EMA and PEX-A, as a relatively organ-specific marker. And then, of course, this inhibin SF1 FOXL2 negative. And then because adult granulosa cell tumor can form in core and chains and solid sheets pattern. So carcinoid tumor should be always in your differential. But I think salt and pepper chromatin is really characteristic for this entity. Of course, we have really good neuroendocrine marker like chromogranin, synopophysin, positive in our carcinoid tumor. And this sex cord-stromal marker are negative. So this is a mimicker. We can see this. Oh, you may see this is coaxial body. However, this is endometrial carcinoma of the ovary. Even more, make you more confusing. Some of these cells make this nuclear groove. You may think about adult granulosa cell tumor, but actually this is endometrial adenocarcinoma of the ovary. There another differential, as I mentioned, in the adult granulosa cell tumor in the stroma. You usually will find this cellular fibroma-like stroma. But this is a true cellular fibroma, deforming this storiform vesicular growth pattern and lack of negative pattern by reticulin staining. So this is the reticulin staining of the granulosa cell tumor. So you can see this reticulin fiber just wrap next and group of cell, not dissect into single individual cell. Another differential entity is about the stroma, that is the sarcoma. You may see some local area like this kind of sarcoma in granulosa cell tumor. And then the cytology feature is characteristic. They have pale, abundant, grayish cytoplasm. And then they're forming this syncytial appearance. What does that mean? That means you could not find where these cells' cytoplasm end. So between these two cells, you do not know which cytoplasm is belong to which cell. So that is the syncytial pattern, and also related to estrogen manifestation. As I mentioned, normal sickle cell can use cholesterol transferred to estrogen, and more estrogen going into the normal granulosa cell, they may also transfer to estrogen. So sarcoma can have both of these two hormone symptoms. And then immunostaining is not really helpful other than reticular staining because it can also express carotene, inhibin, WT1, SF1. More interestingly, they can also have FOXL2 positive immunostaining. But this reticuling just going into the dissect of individual cell as a contrast to our granulosa cell tumor. You see this picture again because I would like to show you, really want you to remember normal thicker cell estrogen. Normal granulosa cell secretes estrogen, but more estrogen can also transfer to more estrogen. Okay, before we talk about juvenile granulosa cell tumor, let me show you some virtual slide. Okay, this is adult granulosa cell tumor. You can see this hyperchromasia area are the tumor. Even low power, you know this tumor have different kind of growth pattern. I zoom in a little bit. We have this kind of tumor cell forming this core and chain. Then they have this, also have this kind of grayish stroma, highlight stroma, forming different kind of growth pattern. But more characteristic, you can see this microfollicular pattern. And then find our friend coaxial body, tons of this coaxial body. This virtual slide just have 20x power, do not have high power, so you could not find the nuclear groove. But you can see, even here, you can see the cytoplasm is really minimal, and then eosinophilic. Like this. Then another area, also you didn't know what is this pattern. Maybe a little bit pseudo-vascular pattern here, or maybe the artifacts, I'm not sure. But here you can see this mimicking kind of like coaxial body here. Not really perfect, not like the previous area. Okay. Another sample of adult granulosa cell tumor. Here, even in this power, you can see the tumor cells are really monotonous. And then they have this solid sheet of glow pattern. And higher power, you can find maybe this is coaxial body. And then see the nuclear structure. This one is good to show you this nuclear groove, really nice. So in granulosa cell tumor, you try to find this cytology feature. And then this slide also shows really classic minimum scant eosinophilic cytoplasm, really minimum. That means you only can see this nucleus, and then the cytoplasm is really minimum eosinophilic. Just remember this characteristic feature. More importantly, this slide also shows the same H&E slide, and then do the reticular staining, show you this characteristic pattern, wrapping groove and nest of tumor cell in the granulosa cell tumor, as contrast to our cellular fibroma and sarcoma.